so I don't forget. All right. So week 8.
Mhm.
We'll cover week 7 and 8 content today. Oh, hang on, let me let these last few students in. Everybody. We're missing one student. All right, we'll get started since it's 4 o'clock. So welcome to week 8. All right, so today we're going to do the quiz at the beginning. And then we will review the quiz. I'll put rationales in the quizzes. So we'll review those, and then we'll go over whatever content from the last 2 weeks we haven't covered. I'm going to bring up some notes that I use, so you can take notes from my notes, okay? And that will take us through the class today, since we're covering 2 weeks worth. Next week, we're just going to be covering week 9, and then we'll do a case study. Okay, so this week and next week is for exam 3, weeks 7, 8, and 9. Okay. Exam 2 grades were posted over the weekend. If you scored below a 78, and you have not reached out to me yet, please do. I'd like to review the exam and see what concepts you struggle with and go over test taking strategies. The other thing I sent out yesterday, I believe, was mid-module assessments to any students that currently have a KGA below 78. So if you haven't I've already heard from a lot of students, and scheduled times to meet. If you could reach out to me and schedule a time so we can talk about, now if we've already met in the last couple of weeks, I'm okay. Okay. We've talked about your progress. But if we haven't met, reach out to me and schedule a short meeting to talk about that mid-mod assessment. Okay. I did post this week what I have so far for HESI schedule for this community class. Okay, I simply am just providing you what's on the master calendar for all your campuses of when you're going to be taking your community HESI. All your HESIs are scheduled through your campus. So I usually put it out in week 8. A lot of times the students haven't heard from their campuses yet to sign up for the HESIs. So I'm just giving you a heads up. Casey's already indicated she has a conflict with another HESI, so she's going to have to go back to her campus and discuss that conflict. Okay, so did everybody see that HESI schedule? Okay, so you have an idea of at least when your community HESI is going to be. Okay, what else? What other questions does anybody have? This weekend, you'll get a fairly detailed announcement. In week 9, I send out an announcement. It's called the roadmap for the rest of the term. And it will be what we have going on in weeks 9, 10, 11, and 12. Okay. So be looking for that. And I'll also have a concept recording for week 9 for next week. But this announcement this weekend will be a roadmap for the rest of the term, because it's going to get busy, right? After this week, next week, we have a lot going on. We have lecture. We have exam 3 reviews. Okay. And you have the master calendar for when those reviews are. Next week, you have, I believe, a case study, and you have an NCLEX, and you have your HESI prep. Those are all due. So next week is a real busy week. Okay. And then in week 10, you'll be taking your exam. And then in week 10, we also have HESI reviews outside of class because you're taking your exam during class. So we have HESI reviews, 3 of them. And again, that is on your master calendar when the HESI reviews are. So week 10, you have exam, HESI reviews, and also your vulnerable populations assignment is due. All right, so week 10 is busy. And then week 11, you'll be taking your HESI, and you'll also have an NCLEX, your last NCLEX. That's the other thing in week 9 you have is an NCLEX next week. Week 9 is pretty busy. Week 10 is pretty busy. Week 11, your HESI and an NCLEX. And then you'll be working on your remediation from your HESI. Okay. So we've got a busy couple of weeks coming up. Questions before we go ahead and take the quiz?
Professor, I have a
Yes,
quick question.
you bet.
You said for the exam 3 is week 7, 8, and 9. I just want to clarify.
Yes, and we're covering week
8,
7 and
9.
8, week 7 and 8 this week, and week 9 next week.
Those are
Yep.
for the third exam, right?
Yeah.
Exam 3.
Yep.
Okay.
And then you jump right from exam 3, and the next week is HESI, weeks 10 and 11. So plan your time accordingly. The one thing one observation I have with meeting with lots of students with regards to exam 1 and now exam 2, if you're not able to attend a live review, one of the 3, I would highly encourage you to be watching the recordings. Okay. A lot of students are not only not attending live for whatever reason, but they're not taking advantage of the recordings. And I would highly suggest you have a look at those recordings, at least look at my recording. Okay. And then if you have time, look at Professor Kershaw, Professor Ford. I mean, we're all presenting the same information, just in different ways. Right. The other resource that I'm a little bit surprised that's not being utilized, maybe a lot of you are, but some of the students I've met with, is the quiz rationales. Right? I would highly encourage you to take a look at the quiz rationales as you're preparing for the exam. Those quiz rationales have a lot of content in them about concepts we're covering. Okay? So don't forget about that resource as well. All righty?
I agree. That's what I use the rationales from the quiz to study from.
Do you? Good.
Mhm.
Yeah, and they help? I bet they do.
Yeah, like my first exam, I didn't do that great on it. I don't think I failed it, but I didn't do that good. But then after that, I started using the rationales from the quizzes, and it worked for me.
Yeah, yeah. Yeah,
Same with me. I did that for exam 2, and it helped me for exam 2.
Yeah, yeah. I mean, overall, this class, well done. Well done on exam 2. Well done for the most part. So congratulations. I'm very proud of you guys. Okay, let's do this. So it is about 4:09. If you try to open the quiz prior to class, you're going to have to refresh it. Okay, because it didn't open until 4 o'clock. Okay, there is an access code. It's the same access code we've been using. I just put it in the chat. It's my last name. So to accommodate for students with accommodations, we will, let's see, we'll start at 4:10, 15, 20. We'll be coming back at 4:25. All right, so if you get done, it's fine to go off camera, but you need to have already submitted the quiz. Okay, if you get done, you can go off camera, but everybody needs to be back ready to go at 4:25. Does that sound good? Let me make sure everybody's muted here. Elise, I can't really see you. I'm looking at a ceiling. I need to see your face. There you are. Okay, so go ahead and get started with the quiz. I'm going to mute myself. If you have any questions, just put them in the chat, please. One clarification. We're coming back at 4:30, not 4:25. I have to accommodate for extra time. Okay, so 4:30. Okay, it looks like everybody's done. You guys could all come back on camera. I had a message from a student in the chat about not being able to see the rationales or the answers. Is that true?
Yes, can't see them at all.
All right. So this started on Monday. My Monday class said the same thing. So I went in and adjusted some settings and told them, let me know if you still can't see them. I didn't hear from anybody. My Tuesday class said the same thing. Went in, adjusted their settings, told them to let me know if you couldn't see them, and I hadn't heard from anybody, so I thought it was resolved. Apparently it isn't. So what I'm gonna have to do, I have the rationales here. And so you're just gonna have to follow along with me today. Take notes, okay? And then I'm gonna put in an IT ticket after class, since this seems to be an issue with all 4 of my sections. I think the students said, what did you say? That it says quiz results are not available to students. So I will copy and paste that into my IT ticket. And it just seems you have all the other quiz rationales, right? Yeah, I don't know what's going on with this quiz. I've looked at all the settings, I've troubleshooted everything, but it's still not showing up for you. So in the meantime, follow along with my rationales today, and I promise you, you will have availability to them. Okay? Once I get this IT ticket in. Okay? All right, how'd you do? Now remember, and my other classes confirmed this, a lot of this information, there are a lot of the questions about infection control you've already had, right? And foundations. Yep. So a lot of these questions are review from other classes you're taking. Okay, so I'm going to go ahead and share my screen.
It's
Pull up-
a lot
Oh.
of review, but your wording is so confusing that I'll pick 3 different things before I feel like, okay, I'm gonna just go with this one.
I'm sorry. I don't mean for my wording to be confusing. Sorry. I try and write straight up questions, so I'm sorry. Let's go ahead and look at the rationales here. Can everybody see my screen?
Yes.
Okay. So, yeah, I mean, this is the quiz you guys have taken that I'm pulling up, so I can see the rationales. I don't know why you guys can't. Sorry about that. So follow along with me. Take notes if you'd like, and know that you'll have access to these soon. Okay? Okay, so which of the following are effective parts of infection control to reduce the incidence of the healthcare associated infections? We call those HAIs. Select all that apply. Okay? So we know that PPE, proper use of PPE, good hand hygiene, and whatever the environment you're in, whatever their environmental infection control measures are, their guidelines. Okay, we don't need to be explaining procedures before starting. So if anybody checked that, that's incorrect. Okay, so let's look at the rationale here. It gives you a nice scenario, a nice synopsis of what healthcare associated infections are. They are infections that patients get while or shortly after receiving healthcare. To prevent healthcare associated infections, workers can use a variety of procedures and policies, including, I took this right from your reading, okay? Good hand hygiene, right? We know that we're always told that staff and patients should wash their hands frequently and correctly. Use of PPE, maybe gloves, masks, gowns, goggles, face shields, or a combination of everything. Okay, we should also be practicing aseptic technique, right? Which is following the standard sterile techniques when performing surgery, care of wounds, or inserting catheters, inserting and caring for medical devices. And then we're always need to be mindful of whatever the environmental infection control guidelines are wherever you're working, right? It simply means that we want to keep the healthcare environment and equipment clean, disinfect surfaces and floors regularly. So that's a really good summary of health care associated infections. Okay. And it's just repeated. You guys know this by now. It's just repeated if you got it wrong. Okay, so I'm not skipping over anything. Okay, question 2. So in addition to observing standard precautions for a client with primary TB, Lisa, the nurse, should also observe which of the following. Well, we know that TB also needs to have airborne precautions practiced, right? In your rationale, I gave you,
See, I selected the airborne precautions and the one under that said no. Can you scroll back up just a little bit? The other one that said no other precautions are indicated.
nope, it's just it's airborne because there are other precautions indicated,
Okay.
right? And I think question 3 talks about TB precautions. So let's do this one first. So in the rationale, I've given you different kinds of transmission-based precautions. Right, so this is a good review, a good summary. We know that standard precautions are applied for all patients. Okay, we add airborne precautions for clients with measles, chickenpox, TB. Right, well, we already know, Amari, that we know that with TB, we're going to be wearing a special mask, right? So that answer of no other precautions are indicated, that's why that's wrong, right? We also, another transmission-based precaution is called droplet precautions. We use this in addition to the standard precautions, right? Because standard is for all patients. For clients maybe that have meningitis, pneumonia, diphtheria. And then there's an additional transmission-based precaution called contact precautions. We use that for GI, skin, wound infections, RSV, herpes. Okay, so there's a good summary of all your different kinds of precautions. Okay, so as a follow-up to Amari's question in question 2, now we know that, let's talk about airborne precautions require which of the following precautions? Okay, so in addition to airborne precautions, it requires an N95, a private room, and we know the clients should only leave the room for essential activities, obviously with their mask. Okay, so this rationale gives you a nice summary of more detail about airborne precautions. Right, so according to the CDC, airborne precautions prevent transmission of infectious agents that remain infectious over long distances when suspended in the air. So in addition to standard precautions, right, airborne is used for suspected serious illnesses transmitted by airborne droplets. Okay, the preferred placement of these patients is in an airborne infection isolation room. That's your private room. That's equipped with special air handling and ventilation. And then the N95 is worn. And then this was one of your answers. The patient should only leave the room for essential activities. Okay, Amari, does that answer your question?
Yes, it does. Thank you.
Yeah, there's several different precautions for airborne, okay? Okay, which of the following medical asepsis principles are sufficient for in the home? Contact precautions. So we're talking contact precautions here. So in addition to standard precautions, which we know from question 2 rationale that we use standard for all patients, we're now adding contact precautions. What does that look like? Gloves, disposing soil contents in a securely tight plastic bag, frequent hand hygiene. No need to change clothes often, of course, unless they're soiled. This rationale provides an excellent summary of what contact precautions are. right? They're a set of safeguards used by healthcare personnel to prevent the transmission of infectious agents that are transmitted by direct or indirect contact with the healthcare environment. This could be in the acute care setting or in the home. Like I said, contact is used in addition to standard precautions to protect against the transmission of any infectious disease. Right, so here's some examples of contact precautions, why it would be used: stool incontinence, draining wounds, uncontrolled secretions, pressure ulcers, generalized rash, ostomy tubes, and or bags that are draining bodily fluids. Clients that have C. diff, maybe MRSA, and wound and skin infections. All right, so the CDC requires healthcare personnel to wear a gown and gloves for all interactions that may involve contact with the patient or potentially contaminated areas in the patient's environment. We also should be using PPE upon entry into the room and discard it before exiting. Gloves, gown, mask, eye protection may also be needed if there's a potential that you're going to come in contact with bodily secretions. Right? So this is a really good review, these first couple of questions for infection control, right? Okay. Okay, this question is about a client with HIV. Okay, so Sarah, the nurse, knows that a client needs to understand that the HIV test cannot identify or may not identify infections that may have been acquired within the previous 3 months before the test. Which of the following statements by the client indicates further teaching is needed? So what are we looking for? What kind of answer are we looking for here?
Something that's not
The
right.
wrong one.
Right. Right. So if the client says, oh, counseling is not indicated for up to 12 weeks because the test is valid as is. It's not. It's not. Okay, the other 3 answers are correct. Right? So the appearance of the HIV antibody can take up to 12 weeks. That's why the test could be negative now, but positive in 3 months. Okay.
That's another one I went back and forth with.
Okay. So let's look at, this is a good rationale about HIV in general. Okay.
Did you say these
needs-
we'll be able to see these rationales later?
Yeah, I'm gonna fix it. I'm gonna put in an IT ticket
Okay.
because this is happening across the board with all my sections. I've gone through all the settings to try and adjust and figure out why you guys can't see it. I can't figure it out. So I'm gonna have to put in an IT ticket, but you will be able to eventually see them. But you can take notes on these rationales and just add to it when they're available, and I'll let you know when they're available. All right, the client needs to understand that HIV tests cannot identify infections that may have been acquired within the previous 3 months before the test. It could take potentially up to 12 weeks. Negative now, maybe positive in 3 months. Right? All people with who have an STD should be counseled about risk reduction activities before and after the test is done. So what do we want to know about HIV? Bloodborne infections spread through sexual contact, sharing of needles, and can be spread vertically through breast milk, right? Or pregnancy, transplacentally, right? It used to be spread through blood transfusions, although now blood is tested for HIV, right? You're also tested after a needle stick, okay, or a high risk exposure. Okay, we know that other sexually transmitted diseases are at high risk for HIV due to traumatized tissue. Some of those other high risk STDs are chlamydia, syphilis, herpes, and gonorrhea. This is in your rationale. We know that open lesions and inflamed tissue increase the risk of HIV. Right? So next question, I think the next two questions are about this is about natural disasters. So we know that natural disasters can be devastating to a community. So the nurse is providing a yearly education class with the community. Which statement by one of the community members indicates that further teaching is required? So we're looking for something wrong, right? Well, the wrong answer, which is the correct answer, is C. Water can be rendered safe for drinking by allowing the water to sit for 24 hours and then pouring water through layers of cotton towels. No, that is not part of the steps we need to take to render water safe to drink. Okay, and A is correct, but not the only thing. B is correct, but not the only thing. And C is correct, but not the only thing. So a combination of A, B, and D is actually the correct answer. All right, so the rationale. And in the community, if you're working in the community, you will be part of disaster preparedness. You'll be part of the impact stage. You'll be part of the post-disaster stage. And so you may be working with clients, working with the community that has lots of questions like, when can we drink water? So as basic as this seems, it's important information to have. So let's look at the rationale. Water can be rendered safe for drinking by, number one, boiling for 3 to 5 minutes. Number two, treating with household bleach. Add 1 ml, which is about 16 drops. That should say per gallon. And let stand for 30 minutes. And then the third is removing water from hot water heaters and commode tanks. So those are the 3 items that need to be taught. And all 3 have to be in place in order for water to be rendered safe to drink. Okay, allowing water to sit for the 24 hours and pouring through layers of cotton towels does not adequately render water safe to drink. Okay. One of the concepts we cover is bioterrorism and disaster. So you will be part of disaster planning and post-disaster management. Okay, this is a bioterrorism question. Okay, the lesions of what can be found on the palms of the hand and the soles of the feet. This was in your reading. Everybody get smallpox? Okay, smallpox, you are going to find lesions on the palms of the hand and the soles of the feet. Okay, you're not going to find that with chickenpox, and that's what the rationale talks about. Actually, the rationale gives you a good summary of smallpox and chickenpox. Okay, so smallpox may start with flu-like symptoms, develop into a rash with red spots. But that rash then develops into deep pustules, leaving craters. That's not chickenpox. Chickenpox does start with a rash. There are red dots, but these dots turn into blisters, small, clear blisters. Very different from smallpox. And that's the difference. The lesions of smallpox can be found on the palms of the hands and the soles of the feet. Chickenpox, they do not appear in those areas. Okay. Now the bioterrorism question. What actions by the nurse accurately indicate understanding of proper management for a client that's been exposed to a toxic chemical spill? Well, if you did your readings in the disaster management section, you'll know that all these answers are correct. Clothing and contact lenses are considered contaminated, should be removed and discarded. Tongs, the use of tongs to prevent touching clothing directly. Eyes irrigated for 10 to 15 minutes, and then clothing placed in a bag, plastic bag for disposal. Okay, so those are all appropriate nursing interventions for somebody who's been exposed to a potential toxin. This is a home health question. Sharing of information from one healthcare setting or provider to another is critical for the community-based care, especially as clients make the transition between hospital and home. Okay, which of the following is an example? Well, the question kind of gives it away. You're transitioning between hospital and home, right? You're not transitioning to emergency room staff. A has nothing to do with it. Post-surgery staff, nope. Pharmacy, nope. Right? We're transitioning from hospital to home. So there has to be effective communication between the acute care facility and the home health agency, right? To make that a smooth transition. We'll talk about that more when we talk about home health, when I cover the concepts. Let's read that rationale. Interdisciplinary communication is required in the home health setting, right? The sharing of information from the healthcare setting to the home health setting, right? The more information we can share, the better the communication is, the easier the, pardon me, the easier the transition is going to be. Think about it. If you have a client that's leaving the hospital that needs physical therapy or occupational therapy or medication management or health aid services or maybe medical equipment, oxygen, that all has to be communicated and set up prior to that patient leaving the hospital, right? So interdisciplinary communication is key. Then the last question is physical neglect. So physical neglect refers to the failure to provide food, clothing, shelter, hygiene, and medical care. Okay, A, C, and D have nothing to do with it, right? So physical neglect occurs when a parent, guardian, or custodian fails to provide basic needs for the kids. Food, clothing, shelter, education, medical care, or supervision and abandonment. That's all considered physical neglect. So I'm going to pull up, there's so much to cover. I'm just pulling up my notes. And we're going to go through these. Okay. So this is an extension of what we've just covered. One of the things that didn't come up in the quiz rationales, but I want to mention, is the epidemiological triangle. That's part of infection control and management. Okay. The epidemiological triangle was in your readings about infection control, right? The epidemiological triangle has to have three things going on. It has to have an agent. What did you learn from your reading of what agents are? What's the agent?
Is that like the bacteria or viruses?
Whatever the problem is, the flu, COVID, chemical exposure, right? It's whatever the virus is, virus, bacteria, whatever it is, that's the agent. The host is us. Okay, so the agent has to affect a host, right? So let's take COVID, for example. COVID is the agent, the host is us. What kinds of things affect a host of how sick that people may get? What kinds of things might affect a host? Are you healthy? Are you
Immune
not healthy?
system,
What?
immune system,
Immune
vaccination
system.
status.
Yep. Health status, comorbidities, right? And then you have your environment. Where's the environment? Is this a long-term care facility? Is it a home? Is it a rehab center? Is it a school? The environment plays a factor as well. So let's play COVID out, for example. Your agent is COVID. Let's say your host is the elderly in a long-term care facility. What happened with those clients during COVID? Were they at higher risk and got sicker? Yeah,
Yes.
right. How about COVID with COVID with high school, a high school? And how about those kids? Those kids got less sick. Does that make sense? So
Mhm.
whatever the agent is, however healthy or unhealthy the host is, and the environment all play a factor in determining how this agent is going to be affecting the host. Does that make sense? Maybe people who have flu vaccines get less sick if they get the proper influenza. Okay. We know that what's an incubation period, right? Is the time you are exposed to the time you start showing symptoms. We used to talk about this when I had the preschools, right? These kids, somebody came in with chickenpox. Everybody's exposed today and they may not get symptomatic for 2 weeks. That's your incubation period. Okay. Couple of terms I want you to know about are epidemic and endemic. In infection control, epidemic means that the occurrence of whatever the epidemic is in excess of the expected levels. That's how we ended up with COVID being a pandemic. Okay, the occurrence was extremely higher than what was anticipated, right? But then you have endemic. What does endemic mean? Endemic means it's always going to be there, right? There's always going to be a risk for flu. There's always going to be a risk for COVID. Maybe we have vaccines that help prevent the severity. But epidemic is the actual occurrence in excess. So lots of cases. Some winters we have epidemic levels of flu, right? But right now, both the flu and COVID are in the endemic levels. They're not going away. They're going to be here. Okay. One of the things we talk about if you're working in infection control in the community is surveillance outbreaks. All right, we have to monitor those. And the schools, I monitored things like pertussis or chickenpox or strep. Okay, we have to be able to have the tools to do accurate surveillance before we have outbreaks, right? So we're collecting data, we're analyzing it, we're interpreting it, we're communicating it to whoever we need to. So in the case of, so let's say pertussis in the schools, let's say we had a kid who was diagnosed with pertussis. Well, we had to do a lot of investigation and education on other kids and information out to the parents who have had a confirmed case of pertussis in your kid's classroom or in the school. Here's what to watch for. Please report any signs and symptoms to your primary care doctor, your pediatrician. Please let us know if if your child's been diagnosed with pertussis. Then we have to communicate to the parents of the kids who may not have been immunized against pertussis. What was the plan? Well, we recommend that you keep your kid home until this passes. All right, that's the follow-up. That's that nursing process of assessment, data collection, interpreting it, communicating it to the appropriate people. Okay. There's certain kinds of, how did it happen? Patterns of occurrence, we call it, which is essentially how did it happen. Okay, so you have different kinds of outbreaks, and I've highlighted those here in the notes. We potentially could have a point source outbreak, which is everybody's exposed to something at the same time. So let's say we're in a train and there's a gas leak. Everybody gets exposed and everybody's going to get ill at the same time. That's a point source. We can pinpoint the source to everybody. Intermittent is exactly what it says. Intermittent outbreak, right? People get exposed over a period of time and they may get sick at different times. This is an example of intermittent would be food poisoning. Let's say there's a bad batch of lettuce at a restaurant, and this batch is served over 4 days. Well, people will get sick at different times. Intermittent. Right? A mixed outbreak. This is person to person spread. Okay, best example is the flu. We pass on the flu to family members or coworkers or kids. Okay, and then the last kind of outbreak, it's called propagated. Doesn't have a common source. It spreads very gradually. And the best example is something like TB. All right, so be able to identify a scenario. Is it a point source? Is it an intermittent? Is it a mixed outbreak or propagated? Okay. Vaccines. We know that vaccines are the most effective method of preventing and controlling communicable diseases. Okay. What do you do in talking with parents that don't want to vaccinate? What do you think the best approach to parents if they don't want to vaccinate? Is it okay?
I think that it's
Education.
okay, depending on what vaccination it is or what the vaccination is for. But I think explaining exactly
Exactly.
what the pros and the cons of the vaccination is to a parent could help a little bit too.
Amari is spot on. Okay. Is education. Talking with the parents, educating them, letting them know that vaccines are one of the most effective methods of preventing, controlling communicable diseases. But remember, there's a federal law that states all children going into schools need to be vaccinated. But the asterisk behind that is they can do an exemption. And states control those exemptions. So for example, here in the state of Colorado, parents can do a religious exemption. Our religion doesn't support whatever vaccination. Physician can do a medical exemption. This child has a certain condition that it would be more harmful to vaccinate. Or you can do a personal exemption. And that simply means I don't want my kid to be vaccinated. Okay, all states deal with that differently, but there is a federal law that mandates all kids in school should be vaccinated unless they have some kind of an exemption. So as Amari said, what we can do, and what I did all the time, was try and educate parents, not force them or coerce them, but educate them. Okay, let's think this through. If we have a case of pertussis in your child's classroom and your child's not vaccinated, what are we going to do? Okay, how are we going to protect that child or the other kids in the school? Does that make sense? So important discussions. Okay, I think we went through HIV. In fact, let's see, STDs are a major public health challenge. Yes, we know that. STDs can be bacterial or viral, right? Bacterial, gonorrhea, syphilis, chlamydia. Okay, but what do you do if you have a viral STD? There's no antibiotic for that, right? It's symptom management. Right, so as you go through your readings of STDs, I'd like for you to read about chlamydia, gonorrhea, syphilis, and herpes, and hepatitis. And just be able to identify what is it? What kind of STD is it? Is it a bacterial? Is it viral? How is it treated? What kind of teaching goes along with it? You know, for example, with chlamydia and gonorrhea, all sexual contact should stop until the treatment is complete. Sex partners over the last 60 days should be contacted, tested, and treated. Can also cause pelvic inflammatory disease, which, if not treated, can lead to significant reproductive issues. What does syphilis look like? Begins as a painless sore or canker, moves to the lymph system. If not treated with antibiotics, in the primary and secondary stages, it become latent and reactivate later. Has to be treated in the primary and secondary stages. What about herpes, genital herpes? Herpes simplex and genital herpes, viral, incurable, right? You can treat it with antivirals, right? Clients with genital herpes, I have this highlighted in blue down here. Clients with genital herpes should inform their partners of the disease to help prevent additional transmission. So have a good understanding of these few that I'm mentioning. With hepatitis, that's also viral, right? We know it's a viral illness that affects the liver. There's 3 kinds of hepatitis. I'm sure you've reviewed this in your fundamentals class, if not your med-surg class, right? Hep A, Hep B, and Hep C. Okay, so just know how each of them are spread and how each of them are treated. And which one has a vaccination available, immunization available? Hep B, right? What else do we want to know about TB? Mycobacterial disease spread through droplets. We went through a lot of this in the quiz rationale. Skin testing, screening is done through skin testing. Right? If they come back with a positive skin test, chest x-ray, blood test is next. We talked about the N95. Bioterrorism and disaster. We started to talk about this. We know disasters happen in 2 ways, natural or man-made. What are some examples of natural disasters?
Earthquake, flood, tornadoes, hurricane,
Yep. What about man-made disasters?
flood,
Fires,
explosion.
wars, pollution.
Yep. Okay. One of the things we talked about, teaching about when the water is safe to drink. But the other thing we potentially are teaching about is how to help families prepare a disaster kit. Okay, there's 4, I have this highlighted in yellow. There's 4 things that are key to this in our teaching. Right? We need to teach to stock enough food for 3 days. We need to teach to review the kit every 6 months for any expired items. We need to make sure all family members know where the kit is located. And we need to make sure that family members know how to turn off utilities in the house. I know you don't really think about disasters in the community, but if you are working in community health, you will be very involved in this planning. Mass casualty exercises with regards to disaster. Those are usually conducted annually, and those bring all the players together who would be involved in responding to a disaster, natural or man-made. Okay, mass casualty exercises brings everybody together. They evaluate communication, response time, roles. So if you're working in the community and are part of disaster planning, you will be involved in mass casualty exercises. When disaster happens, we have to recognize that everybody's going to be in the impact stage. Okay, the impact stage is about safety. Okay, getting people to safety, where are they going to get their information on what's next? What's the status of the community? Where to go to get information, where to go to get medication, where to go get safe drinking water. Okay, it's a very chaotic environment, that impact stage, but working in the community, you will be intimately involved in that impact stage. We already covered if a client was exposed. In fact, I think I just copied and pasted my notes into your quiz. So we went through that. Couple of bioterrorism agents to know about: anthrax, smallpox, and sarin. We did cover smallpox, so let's go through anthrax. What might a client present with a potential exposure to anthrax. Skin issues, okay, cutaneous issues, small sores that maybe develop into ulcers that have a black center, may have GI issues, nausea, loss of appetite, bloody diarrhea, fever. And the other system affected is respiratory. Flu symptoms, chest pain, shortness of breath. So anthrax, you're going to see your skin, integumentary issues, GI issues, respiratory issues. Smallpox we talked about. Sarin, what do we want to know about sarin? A client will present with severe respiratory distress. That's the biggest thing to know about when teaching about sarin exposure. Extreme respiratory distress. Other issues we would have with a disaster would be foodborne illness, food safety. What are we going to teach our community members? Washing hands before handling food, separating raw and cooked food. This isn't just in a disaster, but in general, but this is under the disaster concept. Cooking food thoroughly, not using food beyond its expiration date. The other issue that may come up in a disaster are waterborne illnesses, when the water gets contaminated. We hear about cholera and giardia. That's water contamination. Okay, waterborne pathogens can enter the water supply through animal or human fecal contamination. And then the other thing that may happen post-disaster are vector-borne illnesses. Lyme disease, Zika virus, Rocky Mountain spotted fever, malaria. All these are potential issues after natural or man-made disasters. Okay. Any questions about that? I'm going to cover our week 8 concepts this week: home care, community resources, case management. I'm not going to cover this, care of complex chronic illnesses, because you have all your readings in your Med-Surg book about all these complex chronic illnesses. You should also be studying about these chronic illnesses in your Med-Surg class, correct? So when I say at the beginning of the term that this class, it's community, but it's also Med-Surg focused, think about it. All of these complex chronic illnesses listed here, cirrhosis, COPD, type 2 diabetes or type 1 diabetes, peripheral artery disease, chronic venous insufficiency, hypertension. All those clients may be in your acute care setting, but eventually they're going to go home. So we're going to be caring for, if you're working in the community as a community-based nurse and doing home health, or in medical office buildings, working with people with complex chronic illnesses coming in for appointments. Okay, my point is, we just don't care for these complex chronic illnesses in the acute care setting. It moves right into the community setting, right? So I'm going to ask you to cover those on your own. And it should be a review, actually. Let's talk about home care and case management. That's what I want to focus on. All right, there's 2 important things about home care that's separated from other kinds of care. Number 1, home care is provided in the client's home environment, right? And number 2, it's individualized care. It's not for a group. So those are the 2 distinguishing factors for home care, right? Care provided in the client's environment and individualized. Think of all the things now we do in the home that used to be done in the hospital. Does anybody work in home health nursing? Yeah. Charmaine, what kinds of things do you do?
I read medication reminders,
Mm-hmm.
ADLs,
Mm-hmm.
stuff like that.
Okay.
Cooking.
Okay. Some of the other skilled nursing that we now do in the home that we never used to, let's say IV infusions, PICC lines, catheterizations, wound care. A lot of that used to be in the hospital acute care setting, right? We do lots of direct skilled nursing services in the home, right? Home care used to be thought of as bedbound patients, homebound patients that couldn't get out and get to their appointments. They're homebound. That's not the case anymore. It's much more than that. It's much more than that. Okay. One of the goals of home care is to facilitate self-care, facilitate independence, right? We want the clients to remain in their home. Most clients want to be at home anyway. They don't want to be in facilities or acute care settings, right? We want to try and give them some control over their life. Okay. Remember that the assessment in the home is a lot different than the assessment in the hospital. Okay. Remember, in home care, you are their guest, right? So that relationship, that trusting relationship, that therapeutic relationship with the client, maybe extended family members who live there, that needs to be thought of as well, right? You just can't go in there gangbusters and I'm here to do this and okay, and then I have to go. No, if you're going to be their caretaker as their home health nurse, relationships have to be established so that they trust you and they feel comfortable having you in their home. One of the Medicare is big with home health. Okay, Medicare guides home health services, what they can bill for, what they can receive funding for. And one of the things that Medicare requires for home care is skilled nursing care. Medicare won't cover aides coming in to do ADLs or cleaning or cooking. They will cover skilled nursing care, such as changing dressings, right? Or providing IVs or providing medication. Okay, and this is where the interdisciplinary collaboration comes in the home health setting. Medicaid expects that there'll be interdisciplinary communication so there aren't the overlaps. Home care can get very confusing if a patient requires a lot of resources. Right? I'm going to come back and talk about community resources and jump to case management because caring for clients with these complex chronic illnesses is going to require case management. Okay, case management is the coordination of care. I'm sure everybody's heard of case managers. They are everywhere. They are in long-term care facilities. They are in hospitals. They are in insurance companies. They are in workplaces. Case management is a very effective way to manage care of complex illnesses. Not everybody can be case managed. I wish they could. It would be great. But case management is for really the high needs, high cost chronic diseases. Okay, so going back to home health, there will be case managers in the home health agency. They'll be coordinating the care of what nursing care needs to happen, what other resources the client needs, home equipment, oxygen, PT services, whatever kind of services, IV therapy. A case manager will organize all that, will coordinate all that. Very time consuming and is very costly, but it ends up being very cost effective because somebody is coordinating all those different needs of these high needs clients. Does that make sense? I mean, let's say you have a client that's going home from having open heart surgery and they have lots of needed resources. They need transportation to appointments. They need somebody to help them cook. Or let's say they have family members. They're going home to family. Who can cook? Who can take them to doctor's appointments? Who can change a dressing if needed? Who can meet their needs versus the same client that goes home to no family? Okay, doesn't have any of these additional resources provided to them. That second client is the one that's going to need case management. Just because they had a complex surgery, if they have the support system in place, they may not need to be case managed. And remember, as a case manager, you're the patient's advocate. Whether you're working in the acute care setting, the community setting, the home health setting, the rehab setting, the hospice setting, case managers are advocates. They're looking at the whole picture of what the client needs. Okay? And the last I wanted to go through is community resources. If you are a nurse in the community, you must be knowledgeable about community resources, because every client you interact with that needs resources is going to need a different kind of resources. Maybe they're pediatric resources. Maybe they're geriatric resources. Maybe it's transportation. Maybe it's food. Maybe it's Red Cross. Maybe they need a domestic violence safe shelter. Maybe it's they need a crisis pregnancy center. They need pregnancy testing. Everybody is going to need some sort of resources that you're working with. So as a community nurse, you should be well educated on what your community has to offer. With the simple resources such as Meals on Wheels, to transportation for clients that have complex chronic illnesses and have multiple doctor's appointments. And what do you do with the clients in your community that don't speak English? Who are you going to reach out to in your community to assist you with
An
informing
interpreter.
interpreters, if you have them, interpreters, to reach out to that community to let them know what's available. Maybe it's parents who need immunizations for their kids. They don't know where to go. The other, with interpreters, in addition to interpreters, this is where you seek out your community leaders. Community nursing is all about teamwork. You can't do it alone. There's lots of different factors going on in your community. You may need to seek out leaders. Let's say you have a large Vietnamese population, but you don't speak the language and you don't have an interpreter. How can you get to that Vietnamese population, let them know about childhood immunization clinics, about health fairs, about diabetic support groups, about crisis centers, about food banks, clothing shelters? You have to enlist the help of people in the community that work with those populations. Any population. There's lots of different cultures in all of our communities now. I know when I was working in the schools, I had a whole binder full of community resources, full of people in the community that could assist me with finding resources for populations or cultures I was not familiar with. You have to lean on your community leaders, right? They can be of great assistance to you. So home care, case management, a lot of clients that go into the home to take care of do have case managers that are helping them coordinate all their medical needs, psychosocial needs, emotional needs, transportation, food if they need it, medication services, pharmacy services. There's a lot to be done, a lot to be done. And the last part of my notes was complex chronic illnesses, which I'm going to let you guys. There are several questions on the next exam about the complex chronic illnesses that you're assigned reading to. And what I want you to remember is, remember these questions are clinically focused, like your HESI prep. It's you need to know what peripheral artery disease is. What would a patient present with? What would you teach them? Same with hypertension, what might they present with? So it's they're clinical questions. And I know you do CJ Sims in your other classes, right? Okay, we don't do CJ Sims in this class, but I always encourage students to go back and look at their CJ Sims for their other classes. Because CJ Sims are clinically based scenarios, are they not? I wish we had CJ Sims in community. I've gone into Nurse Think and I have access to all the CJ Sims, and there are some good community CJ Sims. So I try and pull some of that information out as part of my teaching, but you can go back and look at CJ Sim scenarios. Okay, that's how these exam questions are asked, and definitely in your HESI. Okay. So we covered a lot of content today for 2 weeks. You should be able to be almost done with your HESI prep. Right? There are boxes on that HESI prep that you're going to have to, that I may not have covered in class. Maybe it was covered in your med surg class, or it's in your readings, your med surg book, your fundamentals book. But you should be able to have your HESI prep almost completed. Right? We only have one more. We only have one more. We have one more week of content. Next week, I think we only have 3 concepts left to cover. Two, human abuse and violence and cultural influences in nursing. That's all we have left to cover. So I know we're in week 8. I know it's not due till the end of week 9, but if you're working towards on your HESI prep, good. But you have all the information you need now to go get it done and get it turned in early if you would like to. Okay. Questions on content from today?
I do have a question about the HESI though. The HESI prep that we are doing, those are contents that are going to be on the HESI exam, right?
Each box represents a topic,
Okay.
a question. Each of those boxes represent a question. So in the last 2 terms, there have been questions about all those boxes. I don't know what the questions are, but I know the topics that they're
But just the
looking at.
overall content.
What?
Yeah.
Yeah.
Just
So-
the boxes with those are just the overall concept of what the question is asking on the HESI.
Exactly.
That's
Exactly.
what it is.
Yep. Yep.
Okay.
So as you're doing your HESI prep, I mean, think about it. Your HESI prep is a study guide. That's going to be your study guide for the HESI. As you get to each of those boxes and are completing it, also be thinking, what question might be asked? Thinking clinically, what question might be asked? Right? Under disaster preparedness, what question might be asked? Maybe teaching. And we've gone over a couple of things today, teaching about kits, disaster prepare kits. How do you teach about boiling water? Watering? I don't know that those are the questions, but be thinking about what might they be asking with a below the knee amputation. Right? Well, maybe this is what I do in my HESI prep in week 10. We think, what kind of clinical questions? Let's see, below the knee amputation. Maybe, what are we looking for that might be an issue? Circulation, wound, right? Be thinking clinically. That's what you need to be thinking when you're doing this HESI prep. And remember, I said this in week 1. You're going to get out of the HESI prep what you put into it. If you've been working on it all term or working on it the last couple of weeks and putting some thought into it, you'll be fine. If you put it together at the last minute and just copy and pasting stuff in there and it's more get her done, it may be a struggle. But if you're thinking through as you're filling out these boxes, well, questions, okay. What question about what might the patient present with? What might be the treatment? Think nursing process. If you're thinking ADPI as you're completing these boxes and you're taking your time doing it, you're going to be fine. You really will. And I think I've told you before, the last 3 terms, our average HESI in community over 8 sections has been in the low 80s. I think last term we were up to 83.8 or something. I mean, those are good scores overall for 8 different sections. And when I meet with you in week 12, and I've met with students previously in week 12, we talk about the HESI prep. Did your HESI prep help you prepare for HESI? And overwhelmingly, yes. Overwhelmingly, yes. I mean, you've got all the topics in front of you. Give or take, I think there's give or take 5 or 8 topics that are within the concept we covered, but they may be different questions. Does that make sense? So spend some time on your HESI prep. Don't just think of it as, oh my God, I got to get it done. You know, number 1, it's worth 5% of your grade, but number 2, it's your proper study guide for your HESI. So put some thought into it. That thought will help you down the road when you take it. I promise. This isn't my first rodeo. HESI preps are very helpful in HESI preparation. Okay? That's my HESI prep mantra. Let me check I have a couple of Fatima. And it confused me because I never knew you could. But think about how little bleach is in it and you're boiling it. Right? Does anybody have any questions? So next week, just for planning purposes, after class next week, I have my exam 3 review. Okay? If anybody wants to plan accordingly and try and stay after for an extra 45 minutes, I have my review next week. I think Professor Ford does hers on Wednesday, and Professor Kershaw always does hers on Sunday evening, to catch those weekend warriors. Okay? And then I'll get the rationale issue fixed. I can usually sort through those things. I'm kind of mad. I can't. So I have to figure that out with IT. Okay. So I hope everybody has a nice long weekend. Anybody do anything fun? I'm not. Working.
Just doing homework.
Yeah. You're doing homework, Charmaine. I'm working. So gotta do what you have to do, right? But try and carve out a little bit of time for yourselves and your families. But have a good long weekend. And then again, I would say that you guys don't test until Friday. So when you get to week 10, you're not testing till Friday. After you do your due diligence with studying, and by the beginning of week 10, you'll have all the recordings. Listen to the recordings. And then midweek in week 10, Tuesday, Wednesday, Thursday, if you're still struggling with any concepts, because we'll have already had week 9 class. All right. So if you're still struggling with any concepts, reach out in the middle of week 10 and we'll set up a tutoring session and go over with whatever you're struggling with. Okay.
Good.
You have to all get across the finish line here. Okay.
Can I stay after class? I have a quick question.
Yeah, of course. All right. I'm going to stop the recording, but I wish everybody